Good morning, everyone.
Good evening, everyone. And hello, Lorenzo. How are you today?
I'm very good. I'm very good here in Boston. It's morning, so that's why I wish you happy morning and good morning. But I know that on your side of the world, it's evening, right?
Yeah, it's evening, and then we're hoping to create some very interesting content for some entertainment before bed. So, welcome to our online Agree to Disagree episode 5. We're going to introduce the speakers to talk about the static and dynamic guided surgery. I'm Teresa Chanting Sun.
I'm Lorenzo Mordini.
So today we also have a very special guest coming from the section USA. Lorenzo, do you want to introduce him for us?
Yes. It's my pleasure and honor to introduce Robert Levine. Is a diplomat of the American Board of Periodontology, fellow of the ITI, U.S. ITI section membership coordinator, and it's good news that incoming U.S. ITI section chair, diplomat fellow, board of directors, Academy of Osseointegration, president fellow, International Society of Periodontoplastic Surgeon fellow, College of Physicians in Philadelphia, and is a clinical teaching appointment at the Temple University in University of North Carolina. So it's a great pleasure to have Bob with us this morning. Welcome, Bob.
Thank you for the invitation. Excited to be here.
Thank you so much. And we're going to also introduce two of our speakers. The first one is Dr. Jing-Wei Lin. He is an ITI fellow of the Taiwan section. Hi, Jim.
Hello, my name is Jim. How's everyone?
He is also the diplomat of both American and Taiwanese Board of Periodontology, and he's currently the periodontal specialist for Jiayi Christian Hospital in Taiwan. And the next speaker, Lorenzo, do you want to introduce him?
Yes, the next speaker is Alex Lin, and first of all, is a very good friend of mine. Good morning, Alex.
Good morning. Greetings from San Francisco.
Yes, exactly. So as you know, guys, this is a global event. So we have people from all over the world. And actually, Alex this morning had to wake up very early to be here with us. So I really want to thank you for your, for your time. So let me introduce Alex. A lot of you probably know he's an associate professor and postgraduate program director, Department of Periodontology at USCF, University of California, San Francisco, and also is a diplomat of the American Board of Periodontology. Welcome, Alex.
Thank you. Happy to be here.
Great. So we have all of our guests here today, and then that's going to our first lecture by Jim. Jim, it's your turn.
Yeah, let's start.
Hello, friends around the world. I'm Jim Lin from Taiwan. Thank you for the invitation from Young ITI to this Agree to Disagree series. Today, I'm going to share some of my experience on the new technology for implant placement, whether it brings simplicity or complexity to our daily practice. I'm a periodontist in private office, as well as teach digital dentistry and periodontology in Jiayi Christian Hospital and Zhongshan Medical University. Quite a lot of time, residents and students will ask me whether her or his cases is a good indication for guided surgery or not. Before answering the question, we need to understand the know-how behind the guided system. When it comes to static guided surgery, the workflow could be divided into 5 steps. First, we need to have a good quality of CBCT image. For partial edentulation, we will ask patients to bite on cotton roll so that we can separate the occlusal surface of upper and lower teeth. For full edentulous case, fiducial markers is required. Both will help us with the registration process. Second, we need surface scan, either intraorally or extraorally. By this, we can get information of soft tissue thickness and the outline of planned processes. Once we have these 2 files, we install them into the software for registration, meaning the superposition of these two images. Based on the planned processes and our surgical knowledge, we can decide the implant position. And from there, we move on with the design of surgical guide. Thanks to the technology of 3D printing, now we can fabricate a surgical guide within hours. And once we have the guide on hand, then we are ready for the surgery. So let's take this particular case for example. Patient has lost her lower left central incisor. As we described, this is the CBCT and surface scan. We did the registration and digital wax up and confirm the implant position. And as you can see, this is the design of surgical guide on software and how it actually looks like after fabrication. It is crucial that whenever we put the surgical guide into patient's mouth, we need to make sure that it is well seated. In other words, we have to check the intimate contact between the surgical guide and the teeth through the window that we design in advance. For site with small space, particularly for lower incisors and upper laterals, we utilize the partial guided portico, meaning that only the first and second drill will go through the guide and the last and implant will go back to the freehand style. As you can see, once the implant is in position, we apply some bone graft and membrane to compensate the buccal concave and then suture it, call it a day. This is a day of crown insertion, and as you can see, after 5 years, the crest bone is pretty stable without any clinical symptom. As long as we respect the biology, this kind of short-term survival or success is not something rare to see. As for full arch cases, we know that surgical guide can be supported either by bone or soft tissue. In this particular case, we utilized a fixation pin to stabilize the guide intraorally, meaning that there's no contact between soft tissue, bone, and the surgical guide. During the surgery, the guide itself is somewhat like hanging in the air. That's why we also refer this approach to floating technique. In this particular case, I utilized fully guided portico, meaning that all drills and implants will go through the guide during the surgery. By this approach, I don't need to check the parallelism between implants, which would make the procedure so much sweeter compared to the freehand surgery. As for the question, how accurate is static guided surgery? Literature shows us that the angular deviation is no more than, it's about 3.5 degrees, and the angular deviation and the platform deviation and apex deviation is no more than 2 millimeters. If we go with the fully guided portico, it would be more accurate than the partial guided portico. If we compare the static guide system to dynamic guided system, in terms of accuracy, there's no significant difference. In other words, dynamic guide is no more accurate than static guide and vice versa. Literature also shows us that with dynamic guided system, each implant placement would have a longer surgical time by 3 to 8 minutes. Another thing we have to pay attention to is that the accuracy of dynamic guided system is not the same to everyone. If you are a beginner, the deviation will be greater than those experienced surgeon. Why? Couple reasons for it. First, we look at the monitor while doing the osteotomy and implant placement. It is our assistant that take care of the surgical site. They will make sure that there's no saliva contamination to the implant, or they will protect the flap and tongue from the drilling. And this is totally different from the traditional freehand surgery that we get used to. Second, quite a lot of time we may encounter the challenge of optical interference. What does it mean? Let's say if for a right-handed surgeon, if we are going to place implants over upper left quadrant, our arm may probably prevent the sensor from detecting the tracking marker and on the handpiece and from the patient's mouth. Not even mention that we need to calibrate all drills and implants for dynamic guided system. All this will make the system has a longer learning curve and a longer surgical time. In contrast, static guided surgery, the accuracy for static guided surgery is the same to everyone, no matter it's for a single implant or for arch cases, 4, 6, or 8 implants. The accuracy is the same to experienced and inexperienced surgeons. In other words, the typical learning curve cannot be identified. So, take-home message, compared to freehand surgery, static guided system is highly accurate and with pretty straightforward protocol. However, there's one drawback. It requires sufficient mouth opening, particularly for the side of second molar. Otherwise, you cannot fit the surgical guide and kit intraorally. As for dynamic guided system, it is also highly accurate, however, with a longer learning curve and longer surgical time. On top of that, higher purchase cost. In 90% of my cases, I'm happy with the freehand surgery or static guided system. If there is an exclusive indication for dynamic guided system, I would say second molar with minimal mouth opening and anatomical concern. So this is pretty much about my presentation today. So if you have any question, you all are welcome to contact me through the social media or just send me an email. Once again, thank you for joining us and hope you enjoy it. Now I'm excited to the discussion part with my good friends Teresa, Lorenzo, and Alex.
Lecture. Before we move on, I think, Lorenzo, do we want to introduce a little bit about ourselves?
Yes. So, as I said, my name is Lorenzo, and I'm a postgraduate director of Tufts University Periodontology Department here in Boston, USA. And I'm also like an ITI fellow. What about you, Terry?
So for those who don't know, I guess I need to say that Lorenzo and I are classmates. So I also graduated from Tufts University Department of Perio, and I'm currently ITI fellow in Taiwan and also the communication officer of the Taiwan section. So I guess this static guide discussion brings us back to some memory of our residency when we were working together. I guess we did a lot of cases on the static guided surgery.
Exactly. But it's been years that now there's new system, as you know, the dynamic guided surgery equipment, and who else better than Alex can tell us more about this technique? Alex.
So I guess Alex will come.
Hi everyone, my name is Dr. Alex Lin. I'm a periodontist and also a full-time faculty at the University of California, San Francisco. It is my honor to join the Young ITI Agree to Disagree seminar and share with you my experiences in dynamic guided surgery. So this is my overview of my lecture today. I'm gonna talk about the basis related to computer-aided dynamic or so-called navigation guided system. I'm gonna chat about the advantages and the disadvantages of the system. And in the end, I'm gonna share one case with you to talk about how to use dynamic system for the whole process of implant placement. As we all know, with the help of CBCT scan, nowadays we are able to really do a guided implant placement compared to the traditional freehand implant placement. You probably already learned a lot about static guided surgery from Dr. Jing-Wei. So let's focus on dynamic navigation system right now. So how does this system really work? So first, we have to fabricate fiducial markers during our patient intake to provide X, Y, Z, and coordinates in CBCT. Once we get this CBCT information, we will put this CBCT digital information into navigation system software for virtual implant placement planning. And during this planning process, real-time coordination of clinicians' hands, implant location and direction, surrounding anatomical structures would be able to be coordinated to each other in 3 dimensions. In the end, the real-time guidance and feedback on exact implant position, angle, depth of the drill, the implant could be provided back to the surgeon. So with the example right here, we could see that a position sensor is just right above the cubicle. And this sensor would monitor and track the patient's jawbone as well as the handpiece location. And the surgeon could see this feedback immediately from the navigation monitor and place the implant through the monitor's feedback. So what are the advantages of this system? First, we are able to really get a real-time assessment of surgical plan, and we have the ability to modify the surgical plan. Sometimes the surgical plan with our static guide may not be able to work as what we really planned. In this case, we may need to really abandon the static guide and do everything freehand. This is no longer the case for the dynamic implant system. We would be able to really modify our system through the software on the chair side, and then we could still use dynamic navigation system to really place our implant. So second, we are able to really avoid complications arising from freehand surgery. As I mentioned before, a lot of times if we need to abandon our static guide, freehand surgery will be inevitable. But this could be totally avoided when we have a dynamic navigation system. Next, when a patient has a really limited jaw opening, using a static guide with that kind of vertical space that's occupied by the static guide plus the long drill might not be really practical for a patient who has a really limited jaw opening. And this issue could be resolved by using the dynamic implant system. Since we don't really have a static guide in the mouth, we are able to just use the traditional short drills to do our drilling process and place implant. Even without a static guide, this could be achieved with navigation guided surgery. Also, for the irrigation access, the navigation guided system is much better compared to static guided system. We actually saw a lot of case reports talking about jawbone necrosis because overheating the bone, just because of lack of irrigation access from the static guide. And since we don't really need to have a static guide while doing the dynamic navigation implant placement, this issue could be completely resolved. Also, we don't need to have a different guided implant kit when we do the navigation system, since the calibration process would be able to be compatible with the different implant systems. We don't need to purchase different guided implant kit. Last but not least, studies have proven that navigation guided system could be as accurate as static guided system or even better. So today I'm gonna talk a little bit about the evidence as well. But nothing is perfect. With the navigation guided systems, we also need to have extra costs at the very beginning to purchase extra equipment and system for implant placement. There is also a very steep learning curve for beginners. Studies have shown that surgeons may need to use the system for 3 or 4 surgeries before the surgeon can feel comfortable to use the navigation system. Last but not least, there is also a requirement for a sufficient number of points for calibration. So this could increase a challenge, especially for the full mouth edentulous patients. We might need to use the mini screws or mini implants before the implant could be placed through the navigation surgery. So these screws or mini implants would serve as fiducial markers during the CBCT taking process in order to provide a more calibration point for us to do the surgery more accurately. So these are some examples commercially available on the market, including X-Guide, Navident, and robot-assisted surgery such as YOMI. This is a study done by Dr. Chen Kai-Chen, also from Taiwan. So his team showed that for the navigation guided system, the angular deviation right here is about 4.45 degrees. It is much better compared to the static guide and also freehand surgery. The apex deviation and entry deviation could be very similar to the static guide, but also much better than conventional freehand surgery. Similar study was done by Dr. Michael Block and the team. They showed that angular deviation was actually much better compared to partially guided navigation and freehand surgery. The apex deviation, entry deviation was very similar to partially guided navigation, and it was much better compared to freehand surgery. Another recent study by Dr. Wei and the co-authors, they showed that a navigation guided system could provide a global platform deviation about 1.02 millimeters. A global apex deviation was found to be about 1.33 millimeters, and the angular deviation was about 3.6 degrees. All these numbers were considered clinically acceptable, and also these numbers are getting smaller with the advancements of AI technology and different guided systems. So in the end, I'm gonna just show you a really quick case review in terms of the guided system. So this patient had a very, very limited mouth opening. So initially we were thinking about a static guided system. However, the patient was not able to tolerate the vertical dimension of the surgical guide. So we went through a navigation guided system, especially for number 29, the 30 area. So vertical dimension-wise, the patient had a pretty good, decent amount of bone from the bone crest to the iron nerve. However, with a CBCT scan, we could see some buccal bone deficiency at the number 29, 30 implant buccal site. So in the end, we decided to do this implant with the navigation system plus the buccal bone augmentation procedure simultaneously. So this is the final verification of number 29, 30 implant. Everything was planned through a restorative driven position to make sure that our restorative dentist would be able to restore this implant screw retained. So on the day of the surgery, we opened a flap from number 28 mesial to number 31 distal buccally and lingually. You could appreciate a pretty knife edge ridge on top of the bone crest in the edentulous area. Everything was done through the navigation system, so you could see the situation of the navigation system. After the implant placement, we could see some buccal bone dehiscence at number 20 and 30 implant as we expected. The corrugation was done, and the sticky bone and the PRF membrane was then placed, covered by another piece of resorbable membrane, and we released the flap and achieved the primary closure after advancement of the flap. So these are the periapical films that we took on the day of the surgery. We actually placed the 4 implants on the same day using navigation system plus one vertical sinus lift procedure. 1 month after the surgery, everything healed quite nicely without any complications. The tissue looks mature. And 4 months after the surgery, we performed the second stage procedure for these 2 implants, and we did the original graft in order to augment the keratin tissue width on the buccal side of these implants. 3 weeks after the second stage surgery, we got a pretty good band of keratin tissue, and the implant looked mature and ready to be restored. So this is the last slide of my presentation. I hope that you get something from this presentation, and I'm really looking forward to our discussion related to the guided surgery in between a static guide and then dynamic guide. Thank you so much for your attention.
Very nice, Alex. Very good job. I really liked your presentation as well. Thank you.
Great job, Alex. So for the audience, if you have any questions, now it's a time to jump in and then ask us anytime.
I would like to also involve Bob, because you have a lot of clinical experience. And so would you like to share your point? Maybe we can start from here.
I think a good topic would be discussion of the team, the full team, which includes the lab. We assume that the lab in these presentations are up to where we need to be from a quality standpoint. We know that, the dynamic, I mean, my experience is not dynamic, it's static. And I use a surgical guide for about 95% of my cases. And I do a lot of Bob Brain guided surgery, so it's not fully guided, but it's Bob Brain. I do fully guided as well, static. But the static guides need to be really well-fitting, as Jin had mentioned, and that is important. They need to be printed to be strong. They need to also have enough room to have the water irrigation so we don't burn the bone. I mean, I've seen that in my own hands, meaning that we need to have a lab that is an excellent lab that we work with. And being involved with the ITI US section and study clubs, if you're in a study club, you need good quality technicians in your study club, because I can tell you some of the best lectures are from the dental technicians. So I think that's a very important point to have on the team, because the ITI, International Team of Implantology, includes the lab techs. So need to work with a good lab, you'll get good results. And I think that's a very important point.
Yeah, so basically the point that you bring in is excellent. So the first thing is good communication and education. Meaning, as you said, we assume that the lab technician are on our line of thoughts, but actually don't really take it as a granted. So we really need, so that's why study club, especially from ITI, they're great, because it really brings everyone together to the same level of understanding, and also communication, documentation, because let's not forget that documentation is extremely important for the communication between the surgeons, the lab, but also the prosthodontist and the restorative dentist. So we really have to be like members of the same team and speak, I would say, the same language.
And as an aside, if you're the surgeon or the restorative dentist, it's important to be on those calls. And I did Zoom calls. The labs we would use would be up in Boston or in Florida. And I need to have my surgical experience as part of the menu, because the lab will put the implants where they think they should go. I could tell you I would move a lot of these implants around slightly from a surgical standpoint, emergence profile standpoint. So I think that's really important. It's the team. And who always benefits is the patient when the team works together. So
I agree. And so let's talk a little bit about what Bob just said. So let's say a situation where you plan the guide, you receive the guide, the static guide at this point. And let's say clinically there's something that doesn't really convince you from a surgical point of view, from a prosthodontic point of view, and you have a static guide. So what do you do at this point?
is that an open question for everybody here? So
Open question about it for everyone.
Question for everybody. Yep.
Or that static guide breaks, or it doesn't fit. I mean, that's
During the
whole
surgery, what would be your solution, Jim?
So actually, I still do quite a lot of freehand surgery. That's the best principle we every one of us should be familiar with, just in case that the surgery doesn't go with the plan. Like Dr. Levine say that what if the surgical guide break? So basically, everyone should be familiar with the freehand surgery. That's the basic. As we discussed that no matter it's static guided surgery or dynamic guided surgery. So in the future, maybe when the cost getting down, it could be the standard protocol. But I have a question about this for every one of us as well. As an educator in school, how we gonna teach our residents for freehand and guided surgery when we're doing the implant placement? Are we going to have them the guided approach for every single case, or how are we gonna start with the freehand surgery? Yeah, that's it.
Teresa, what do you think?
I guess it's very important that before moving into guided surgery, to be very familiar with the freehand. So you have the capability of solving the problem when your guides is not the plan as you want. So I guess that's a fundamental for all of the surgeons, that you can still work with the freehand. But I guess that's the beauty of the dynamic navigation will be when the static guide has some error and then cannot be used during the surgery, then you may not have the flexibility. So I guess maybe Alex, you wanted to tell us about your experience?
Sure. Since I'm on the team dynamic today, so I'm gonna say something about dynamic procedures. So just like Teresa mentioned, the beauty of dynamic surgery, we are able to really modify our treatment plan in the middle of our surgical treatment. As long as the calibration process is well performed, we could adjust a small degree of angles, or make a little bit, a few millimeters of the adjustment for our final implant placement. So breaking a guide, especially a static guide during a dynamic surgery, is not a problem, because we are able to still use dynamic system to really continue our surgical procedure. However, I don't want to say that 100% of my implants are dynamic procedure. Actually, no, I probably used 10 to 20% of the implants in my own office as a dynamic procedure. Most of my implants are either static guides or freehand surgeries. But I believe in the future, down the road, static guide or dynamic surgery could be a standard of care. It's similar to what CBCT has brought to us. 10, 20 years ago, when CBCT just got on the market, people would be a little bit resistant because it was a new technology. But nowadays, everyone's using CBCT. I'm sure that down the road in the future, once we can bring the cost even less, we can make the guides more accurate. Static guide or even dynamic system would be a standard of care that people would use this kind of systems on a daily basis. So we need to appreciate what technology has brought to us, and we look forward to the future for our future practice. That would be really beneficial for our patient care.
Let me, before we move to because I know like the people from home, they're watching us live, they have some question. First of all, let's define what do you guys consider by freehand? So do you meaning like with a suck down, with any sort of wax up indication that it will tell you where the future crown will be, or you mean like completely with no absolute reference for your wax up for your future crown? What would you define freehand? Yes, Jim. Yes.
I answer first. Yeah. So, well, to me, that even with the step down, I would still call it freehand surgery. At least you need to have your prosthetic reference, so that you at least you're placing the implant to the reasonably restorable position. Otherwise, you just put the implant into where there is bone. That doesn't make any sense, right? So for freehand surgery, I would say, as long as you have a vacuum foam, you have prosthetic reference, but you don't have any computer-assisted guide or navigation system, I would call it freehand surgery. Yeah, pretty much about that.
Very good.
Yeah, for me, I think freehand surgery is nowadays I review CBCT since we get CBCT for almost all the patients who need implant, but without any type of the pilot guide or any kind of set down, I consider the freehand surgery. Just go in to a surgery without any sort of a guide. Bob, what do you think?
Freehand to me means no guide at all. Whereas I like to call it Bob guided surgery, or Bob brain guided surgery, from a standpoint of I'm using an anatomically correct surgical guide with a buccal aspect, know where the final gingival margin is, so I know vertically how deep to place the implant, 3 to 4 millimeters below that mid buccal. But I have freedom on the lingual. I don't want a hole where I could bring acrylic into the site. So I have the palatal open. I generally in the aesthetic zone will go towards the cingulum, or as Joe Kahn and your group, Alex, will go towards the central portion, the incisal edge, because we could go with the angle correction now with our restorations. But to me, that's a partial guided. It's still static, but not freehand is what I'm talking about. So freehand in my mind means you're free. You're partially blinded restoratively, and maybe just going with what you see into proximally, obviously radiographically, and what's going on in the opposite jaw, because you've got to aim somewhere. And all of us have done freehand. And where I would indicate doing it is sometimes on emergency visits, extracting a molar immediate implant, where I could use the opposite jaw occlusion to direct it and mesial distally. And my dental assistant, who's got great eyes, can say, Bob, you need to, bring it up maybe a millimeter or so, because you need everybody on the team to be really engaged in what you're doing.
Yeah, that's very interesting, Bob. Speaking about an immediate implant placement, I guess one of the questions from the audience, Yasmina, is talking about this specific aspect as well. So I guess would guided surgery help with the immediate implant placement? What do you think?
I think it's great. I like to feel the bone. So most of my cases are not guided, static guided. It's, again, Bob brain guided from a standpoint of using a surgical guide with a lingual cutout. But where I would use, and this is with experience with complications, is where you've gone into a site where you've bone grafted, there's no buccal plate. So that's a situation where you go back in 3 to 4 months and that bone could be a lot like a type 3, type 4 bone, which is soft. And that the drills have a tendency of migrating. So that's where you would want to be able to go in fully guided to be able to, maintain what you've built on the buccal. And I've used it also in posterior maxilla, for example, where we have the sinus, say, at 3 or 4 millimeters. So we have little vertical bone left, and I want to place immediate implants, and I'll, do the discussion with my lab, and I'm placing it to the level or almost to the level of the sinus, and the rest of that I'm doing basically free guided or Bob brain guided. But it gets me in a position, gets me to the top of the sinus, and then we'll break through using the Versa technology, which is excellent to place implants, as I believe one of your cases, Alex, you had showed that in the upper. So those are two indications that I really like. Or if there's multiple implants adjacent, I will definitely consider guided. And I like my platforms at the same height. I don't like seeing platforms where there are different heights. So it's also very important to take an X-ray before you say I'm done and make sure everything is perfect. It's always about the patient, always. So.
We also have another question. Yes,
Go
ahead. Go ahead, Jim.
Yeah.
Jim. I would like to comment on the guided surgery for immediate implant as well. That to me, this is a little bit tricky because sometimes my friends may show me that they use the static guided surgery for immediate implant, but it doesn't work for them. But to me, this is a tricky clinical scenario. Why? Because we know that when we do the osteotomy for immediate implant placement, the drill will move toward the least resistance, most likely buccal side, right? So if you work with static guide and you do it fully guided, particularly for your first drill, pilot drill, you'll notice that your guide is kind of pushing toward the buccal side. So meaning that your guide itself may not be that stable. So it is crucial that you have to hold your surgical guide firmly, make sure it's not rocking, it's not flipping, and you do your guided surgery. That's how you could work with immediate implant placement.
That's a good point.
But I think for immediate implant placement, I find it tricky to do it for the pilot drill. Sometimes you need to put at an angle with your pilot drill to make it into the exact position that you want. But I guess if you're using static guide, then you'll lose that freedom. What do you think about this point?
Yeah. Actually, when we do the immediate implant, most likely we need to, for the pilot drill, you want to do it toward the palatal side first, and then you change the angulation of your drill, right? So with the static guide, there's 2 ways you can do it. First drill, you just do it freehandly, or you do 2 guide with different orientation. I know this is kind of complicated, but if you want to work with the static guide, that's how it should work.
Have you tried with different angulation, like this kind of design? Because I'll be interesting to know how much offset you would like to aiming for example, when you see on the CBCT, like what will be the design of the guide, the angulation, I guess?
Well, I would say this is not something I can give you a clear answer about the angulation itself, right? But the first pilot drill is help you to provide a stable platform for the next drill. That's the main purpose of it. So as long as you can create a stable platform for your second drill, that would be good. That's what I would say for the pilot drill. Yeah.
I'm curious, any of you use piezo surgery or similar type of devices with the osteotomy drills? Because I find they're really helpful because they don't bounce at all. And I've used it with static and non-static type of guides, and they just go right exactly where you want. So that's a helpful hint as well.
Interesting.
So
Yeah,
I haven't used piezo, but just like a large rumber. I mean, of course, the same size of the first pilot drill, just to decrease the density of the most likely is the palatal wall. The one that will determine like the drill to move backly, like Jim was saying. This is exactly what I experienced too at the beginning. So then you will have to correct the first pilot drill, because let's not forget that as you stated in your lectures, we have some different angles. So we have like a different angle of entrance compared to the plan, and also some vertical discrepancy. So let's not remember that also the sleeves, they have like a little bit of play. So there's room of error. So don't, for the people that are listening to us, don't trust 100% either of these techniques. So you always have to use your brain. So if you understand that there's something that's not going according to the plan, you definitely don't go ahead with your guide or with the static. So you need to sit down and think with your brain before you do any damage, because let's not forget that fully guided and dynamic navigation, it's 100% guarantee your result. So you always need to wear your brain and use it. Okay, let's not forget this.
When we look at the reason Swiss cheese model for complications, we are the last on that, which is the surgeon. And we have to know when to abort. When you're feeling that sweat coming up your back and your neck and your hair standing up in the back, abort. You'll feel much better, and that goes away. So, and you come back to fight another day. So we're here to also, again, about the patient and preventing complications. So Alex, could you comment on this so far? What we're talking about?
So again, team dynamic right here. So if we are gonna try to do the immediate implant placement with dynamic system, sometimes it's a challenge, especially that if we try to engage the palatal bone. Palatal bone is always quite dense, and like everyone has commented, it's gonna really be shifted towards the buccal side. A lot of time I feel that when we use the dynamic surgery, we even needed to use a needle burr, like a needle diamond or carbide burr, to be our initial pilot drill to really create a dent on top of our palatal side, or a rumber. And once we really created this pathway, then we can start with our first pilot drill to really go down there, like a 2.2 drill. But before the 2.2 drill, we may need to consider using a rumber or a needle burr in order to really create that pathway. Because if we don't do so, it's very easy to really have the osteotomy shifted towards the buccal side. So I think using a dynamic system or a static guide would be quite beneficial from my standpoint for immediate implant, especially if we really try to do immediate provisionalization as well. Everything could be pre-planned, and down the road, everything can be very streamlined, and patient could benefit from the whole dynamic or static guided system.
Always think of biology, copious amounts of water on that initial drill.
Yes.
Also. It's really important.
Yes. Yeah, that's important. Mm-hmm.
That's the big advantage of the dynamic system, because there's no there's no resin or device that is blocking like the flow of saline into there. So definitely this is a big advantage of the dynamic.
So I guess we still have some. Go ahead. Yeah. Sorry about.
No, Teresa, you just got a question after. That's all for everybody.
Oh, Great. So let's answer another audience questions and then come back to Bob's question afterwards. So I guess Elsner has one more question for us. It's nowadays with static guide development and dynamic, is it possible to use single drill step in D3 or D4 bone patients?
Yeah, so I'm gonna tackle that first. Since we all know that just in recent months, another implant company just pushed out a new system, so-called N1 system, that you might be able to use one single drill for your osteotomy and place implant. I think that's potentially beneficial if it could be applied to most of the implant sites. I think at this moment, we still need more evidence on this new protocol. We don't really know the outcome of this protocol yet. But D3 and D4 bone, if you are not placing a wide diameter dental implant, maybe using 1 or 2 drills is possible. But the new system, N1 system, they were trying to push out this drilling protocol without irrigation, which could be a little bit concerning because drilling osteotomy using a low RPM drilling protocol without irrigation, we still really needed to have more evidence on this protocol. But for the soft bone, D3, D4 bone, it could be possible using either a static guide or a dynamic system.
Actually, Ali Thomasab from the Netherlands reported, I think it was 2020, 2021, that using RPMs less than 200, no water, the bone that you actually are pulling out is all vital. So that's something that I've used also because of Ali's research. So, and it's helpful because you can mix it with whatever bone graft you'd like, the xenograft or an FDBA type of bone. But that's a good point, Alex. Question I got, the day that you all take impressions, digital impressions, and you're making a static guide, how far out do you want to, what's the most far out you want to schedule that patient? Because you have a tendency in partially edentulous, broken down teeth, that teeth could move. So the guide wouldn't fit. So is there a concern if patients are canceling or rescheduling or whatever as to the time from T0, which is when we make the guide, you know, the impressions, to the day of surgery? I'd love to hear what you guys will say.
Maybe answer this question first. Actually, most likely I will schedule my patient in 1 or 2 weeks. But I do notice that I have worked with my lab quite for a long time, and we have very good experience. So even now, within 3 days, I'm good with it. I don't need to do the try-in for the surgical guide itself. And most likely, during the day of surgery, I just put a surgical guide in. Most of my case, I would say probably 9 out of 10 that will fit well. If there's need any correction, minor correction only. So that really depends on how the experience, how you work with your lab. That required communication quite a lot. At the very beginning, we probably need to schedule it 2 or even longer before the surgery.
What if that patient cancel once or twice? What is the concern? What is the timeline that you say, you know, we need to take new impressions or, you know, do another digital? I think this is really important because this is real world stuff.
Yeah,
I don't have an answer to that, but I wanted to hear what you all have to say, if there's anything literature based on concerns.
Well, I don't have an answer either, but I think Alex would agree with me that this issue won't be happening with a dynamic guide, right?
Yeah, I mean, as a team.
So Alex, the
because
questions will be for the registration. Does it have like a timeline as well? Because you mentioned in your lecture that on the CBCT you actually need some marker to put it on to take the CBCT. So I guess you might be facing the same questions as well, right?
Yeah, most of the time the issue is that if you are gonna really merge the CBCT with the patient's, the real time jaw, then you need to have some markers. For dentate patient, we use the teeth as markers to really merge both. But yes, there could be some deviations if you schedule your patients a month after the CBCT was taken. So I know nowadays a lot of offices actually have an in-office CBCT. So in the worst case scenario, you may be able to get the in-office CBCT on the day of the surgery, and then you would use that CBCT to really do the calibration, and that will resolve this issue. However, whenever I use static guide, I feel that it depends on if the patient has like a retainer, or if patient has even a occlusal guard, could be beneficial to really maintain most of the teeth in position. Otherwise, sometimes I found that even 3 months after the initial guide fabrication, the guide would not even fit. Then in that case, a lot of time we may even need to modify the guide to really make a guide a little bit flexible to really fit patients the current dentition, or we may even need to abort the guided surgery and just do it freehand. That's my experience. Yeah. How about you, Bob and Teresa?
I personally, so far, don't do that much of dynamic navigations cases. So I have more experience in terms of static guided surgery. But I do see some limitation in terms of, I guess the biggest limitation for me will be if sometimes I'm doing full arch cases and then with a bone fixation pin that you cannot easily remove on the full arch guide, like in and out very easily, then I guess that brings a lot of restriction in terms of how you operate during the surgery. That's the time I'll say, oh, maybe navigation will be more as an indication for that, maybe. I'm not pretty sure. Or some static guide, they have, for example, the magnet or some like indentation that you can sort of like have a frame with a bone fixation pin, and then the device that you can move on and off. I guess that might be one solution as well. But I guess as a case gets more complex, the guided system is more important, but also you can see both advantage and disadvantage of both system, I guess.
Yeah, so Teresa, since you mentioned about the full arch guided surgery, I want to comment on that from the dynamic standpoint. Because nowadays still there is one limitation of dynamic guided system using this kind of system in a full arch surgery. It is that the need of placing fiducial markers in a jawbone before the CBCT scan. Because when we really go into a dynamic surgery, we needed to have some certain markers, as I mentioned before. But for full edentulous patients, the markers would be some titanium screws or mini implants inside the jawbone before the CBCT scan. And that would require a second surgery even before the CBCT scan to place the fiducial markers in the jawbone. So a lot of situations using dynamic surgery, if you don't have a CBCT in-house, then you need to place the titanium screw first and get the patient to take CBCT and come back for the surgery. A lot of patients are not willing to have a secondary surgical procedure even before the full arch implant placement. So that is still a limitation of the current dynamic surgery system. However, I know with a lot of new AI technologies, some companies are already developing a newer version of the fiducial markers that they don't require this kind of mini implant placement before the CBCT is taken. So we are very excited about the future because with the advancement of the different photogrammetry, we might be able to achieve that soon in the future.
Also, I would like to highlight what the question of Bob was very interesting, because he also said scan. And I'm assuming he was mentioning intraoral scan. So let's not forget that I still see some, and I speak with some labs, and they say, "Oh, I received the cast, maybe with like an alginate, and now I have to make like a static guide." And it doesn't really fit, because we know there's a lot of besides expenses from practice, also the distortion of the material, the stone. So that's a problem. So nowadays we know the intraoral scanners, they really are I would call it like the standard of care for this kind of technology. And again, with dynamic guide, another advantage that we discussed at the beginning is that probably the lab is not so involved, right? So also the expenses for the practice and for the patient are a little bit less, right?
I guess will be more investment from the beginning, right? For the entire system. It's like a huge investment for the
Yes.
dynamic navigation, maybe.
Yes, definitely, definitely.
Yeah.
And just speaking with, Dr. Ganales, Jeff Ganales, a close friend, ITI fellow in Florida, he was a beta tester of the navigation systems I'd seen about 20 years ago in his practice. And he uses the navigation, which is actually the dynamic, which is nav, as well as robotics, about 10% of the time in his practice. So as Alex mentioned, I think that was about the same number that you said you use clinically. And
Yes.
he really likes the ability of not only the drilling from a standpoint of being able to get better primary stability because it's more of a circular versus a maybe oblong shape by doing freehand. But there is definitely, robotically speaking, it's a very expensive investment compared to a navigation system. So that obviously the front end costs are important to young clinicians. But I think to stress what Lorenzo mentioned, today standard of care is really digital scanning your case and having somebody in the office or yourself doing it right from the first. So you need to have that practice and need to get the lab involved in, what did I do right here? What did we do wrong? And just knowing how to scan is very important.
Very, very good points. Very good points. So, actually, I'm to be honest, I'm having a lot of fun talking to you guys because I think this conversation is like bringing a lot of great discussion. But unfortunately, we're almost getting close to the end of the discussion. So I will actually ask Alex, what do you think is the future of the dynamic guided surgery? And then also Jim can answer the same for the static portion.
Yeah, sounds good. So in terms of the dynamic system, as I mentioned before, AI technology is really, really around the corner. And we have seen a lot of improvement in terms of the photogrammetry to really help us to do the calibration process much sooner and much easier. Also, segmentation part is also something AI has been helping us a lot. So in the past, the surgeon had to go in to do all the segmentation thing, but now AI would be able to do the segmentation for us in a really fast manner. So the next generation of the AI system and AI dynamic assisted system would be very exciting. And we will be able to see that dynamic surgery could be used not only just for implant placement, it could be used for socket shield technique, could be used for sinus window preparation. All these kind of the surgical procedures would be able to be integrated with our dynamic system in the future. So I'm very excited about what we can do down the road. How about you, Jin, from your standpoint?
Yeah, for static guided surgery, most of the surgical guide now we are resin based, which actually we are working with the metal printing guide. The reason for it is that we can, with the metal itself, we can, the strength will be stronger. So we can reduce the bulkiness of the surgical guide. By this, we don't need to raise the flap to that much aggressive. And also we can create more space for irrigation. As we mentioned, this is an issue with the static guide. So metal-based surgical guide could be the future for static guided surgery. Yeah.
Are they available now, Jin? Are
Sorry?
they available today? The metal-based?
Yeah, actually it is. It is. Yeah. I would say, especially for the full arch case, the surgical guide itself, we can just print it either over the buccal side or lingual side, so that we don't need to rest the flap that much aggressive. That would really helps a lot. Yeah.
Excellent. So thank you so much, Jim and Alex, for your wonderful presentation, and also our special guest Bob for joining us today. And for sure, this Agree to Disagree series is not only online version that we will also want to see you in ITI World Symposium, which is coming up in 2 months in Singapore. And then so you can see on the screen, if you haven't registered, maybe I guess this is probably the very good time for you to register. And not only the ITI World Symposium, we're going to also have the Young ITI Day at the same event, which will be May 8th, one day prior to the World Symposium. So thank you so much.
Thank you, everyone. Thank you, Bob. It was an honor to have you with us. Wonderful presentation, Alex and Jim. And also, I would like to acknowledge the hard work from Ron and Jasmina, because they made this Agree to Disagree possible with their skills and their organization. So thank you, everyone. And please come to Singapore. We would like to see you there.
We'll see you in Singapore.
See you soon.
The largest
See you in
in
Singapore.
the world.
See you in Singapore.
Take care.
Bye, everyone.
Bye.
Bye.